Hello and welcome to the Headache Lecture from Self-Care and Alternative Medicines. This is Chris Herndon. I'm one of your pharmacy practice faculty members, and we'll be covering a little bit today about the different types of migraine. Now, migraine headaches can affect both men and women. However, women typically experience headaches, specifically migraine, 3 times more commonly than do men. Today, we're going to talk about some of the different primary headache disorders, including tension headache and migraine. Other types of headaches, or secondary headache disorders, are usually caused by something else. This can include trauma, like if you hit your head or have some type of traumatic injury, infection, like meningitis. Drugs can cause headache disorders, either prescription drugs that actually have headache as a side effect, or if you overuse analgesics, you can have headaches that are termed rebound or medication overuse headaches. And then obviously sinus headaches can be considered a secondary type of headache disorder. Now, in order to completely understand the pathophysiology behind headaches, first thing we have to do is refresh our memories around the 5th cranial nerve, or the trigeminal nerve. As you can see here, the trigeminal nerve has 3 predominant branches: 5-1, 5-2, and 5-3, or otherwise called the ophthalmic nerve, the maxillary nerve, or the mandibular nerve. You'll notice here that the ophthalmic nerve, or the first branch of the trigeminal nerve, innervates these green areas and can involve some of the nose, some of the supraorbital areas, as well as the forehead. The maxillary nerve feeds obviously the maxillary areas. It can involve some of the sinuses, the upper lip, and the temples, for instance. The third branch, or trigeminal nerve branch 3, is also called the mandibular division, and that can involve the lower lip, some of the lower teeth, even the tongue, the ear, and some of the further back posterior temple. Now, why this is important is that all 3 of these branches feed into one common nerve. So frequently, any time that you affect one of the nerves, you can affect the other 2 nerves also. What you'll wind up hearing is some patients that have a migraine may describe that their sinuses become very full, or they may say that it causes their teeth to tingle. Likewise, sinus headaches, whether it's just sinus pressure or it goes into a full headache, can trigger migraines and other types of headaches as well. The trigeminal ganglion, or the trigeminal nerve, actually sits in the back of the head near the neck, and what can also wind up happening is patients who have a severe tension, muscle spasm, or even tight muscles, that can also anger or stimulate the trigeminal nerve that can cause what we typically call tension type headaches. When we look at the different types of headaches, it's really important to take a look at the different types and where we might expect to see symptoms. And I want you to keep in mind that we did just see the trigeminal nerve and the 3 branches, and so hopefully this can start making some sense. The first one is sinus, and while this is one of our secondary headache disorders, typically what you see is pain that's really localized to the sinuses. It's usually behind the forehead or cheekbones, compared to cluster tension or migraine. If we look at cluster, this is usually just around one eye, and it's usually unilateral in nature. Tension type headache is usually more band-like. Think of like something squeezing your head from both sides. It can be really uncomfortable. It can be due to stress, anxiety, muscle spasm, lack of sleep. There's a whole different host of things, but it can usually be bilateral in nature. Migraine, in contrast, is usually unilateral. It can involve really any of the 3 trigeminal nerve branches, as you can see here on this figure, and is usually associated with pain, nausea, and even visual changes. So why do we care about headache? Well, if you think about who's involved, 13% of the United States population actually describes some type of migraine or other disabling headache. In fact, 20% of all neurology visits are due to headache pain. So it's not surprising that this is a huge area of interest for primary care providers, and we as pharmacists can certainly have a very large role to play in the treatment of these patients. One of the difficulties in identifying different types of headaches is really understanding the true pathogenesis of these different types of pain syndrome. The pathogenesis of migraine really has a lot of different theories behind where it might actually come from. For the longest time, for instance, when I was in school, we thought that migraines were caused by dilation of blood vessels in the brain. Well, that's been disproven up to this point, but it may play some small role in this. But really what we're operating on now is something called the neurovascular neuroinflammatory theory. And this basically involves a whole host of different things that can play a role in headache pain. One of them is sensitization of these trigeminal afferents. So something stimulates those trigeminal nerve branches that goes back and tells the trigeminal nerve that it needs to really pay closer attention to what's going on. Once the trigeminal nerve is activated, it then sends signals back out to the brain and to the different areas that the trigeminal nerve fibers innervate that cause vasopeptide release. And so when these vasopeptides are released, they cause neuroinflammation. They can cause what we call protein extravasation of the vessels, or proteins start leaking out. And that further upsets those sensory nerves and can also stimulate something called glial depolarization. Now, all of this summarized together can really result in what we call central or cutaneous allodynia. And that is when your scalp just becomes so sensitive that it hurts even to touch it, let alone brush your hair, blow dry it, lay down, wear a hat, etc. So at this point in time, this is where we think most of the pain from headache actually comes from, but there's still so much to learn that we're really not sure what the true inciting cause is. One important thing we need to talk about is the migraine continuum. So if you think about the migraine continuum, this is really a process of events over a period of time that include premonitory symptoms, aura, headache initiation, sensitization or allodynia, resolution of the headache, and then postdrome. Now, if we look deeper into premonitory symptoms, really what these include are that they're almost like weird feelings, but not really descriptive of an oncoming headache. They usually occur in about 60% of migraine sufferers, and they can come on anywhere from 1 to 2 days before the actual onset of the headache. They can last hours as long as days and can include euphoria, some depression, irritability, and there's a host of other symptoms that can be involved. Aura, on the other hand, occurs in only 25% of migraineurs, and these symptoms immediately precede the headache. So premonitory symptoms can be well before the headache, but aura must be immediately before the headache. These typically last about 1 hour or shorter, and they consist of what we call visual floaters or scotomas, diplopia, aphasia, dysarthria, confusion, paresthesias or tinglies, and cyclical vomiting. As soon as the headache is initiated and we start to see a ramp up or worsening of pain, we reach a point of maximum sensitization, and this is usually where the headache is the most severe, and we typically will refer to this as central sensitization or cutaneous allodynia. Allodynia basically refers to extreme pain from light touch versus a normally noxious stimuli. When we think about the actual headache, for instance, typically these headaches, and this includes initiation, sensitization, and the overall resolution, usually can last for more than 4 hours. And these symptoms include unilateral throbbing, pulsating symptoms, that allodynia we were talking about, and we get symptoms of nausea, vomiting, photophobia, which is sensitivity to light, and phonophobia, which is sensitivity to sound. Although not much is really known about the postdrome of a headache, at this point in time, we think that it typically immediately follows the headache, and patients will describe symptoms of general malaise. They feel drained, exhausted. Some can actually feel revved up or euphoric, but like I said, we don't really have a lot of good research on who experiences postdrome and what the actual symptoms may entail. One of the key features of taking care of a patient with any type of headache, regardless of tension type or headache, is knowing what their headache triggers are. Headache triggers, and this graph is actually representative of the frequency of these triggers, include stress, changes in hormones, fasting or not eating, weather changes, and lack of sleep. We'll cover more about this in the lecture, but they go on, and the most important way to try to identify a headache trigger is to have the patients keep a headache diary. Oftentimes, we don't know what causes the headaches, but if we keep a very judicious diary, we can start to find out a little bit more about really what makes their headaches tick. So we keep talking about all these different types of headache disorders. Let's spend a minute and compare some of them. So we're going to talk specifically about tension type headache, migraine headache, and sinus headache. You saw earlier where those distributions may actually be, but let's talk more focused around the location of these headaches. So from a location standpoint, tension type headache is typically bilateral, migraine headache is usually unilateral, And sinus headaches can be more facial, can involve the forehead, or periorbital distribution. If we look at the nature of these headaches, tension type headache usually is a diffuse ache. Patients will describe tight or pressing type pain. Migraine headaches, patients usually will describe intense throbbing. And sinus headache patients will usually say there's pressure behind the eyes or their face. If you look at the onset, usually patients with tension type headache will describe a gradual onset, where migraine patients will say that it usually comes on very suddenly and without prediction. Sinus headache will come on with sinus symptoms. Duration of these headaches varies, but the duration of a tension type headache is usually hours to days. A migraine headache is hours to somewhere between 2 and 3 days, and remember that you have to have a headache for at least 4 hours for it to truly be a migraine. And then for sinus headaches, these usually go away when the sinus symptoms resolve. All of these headaches can be associated with non-headache symptoms. The tension type headaches can be associated with scalp tenderness, neck pain, or muscle tension. Migraine headaches usually always involve nausea or vomiting. And then sinus headaches can involve nasal congestion or rhinorrhea. So now that we've figured out what the different headache types are, let's figure out which ones we can actually treat using self-care recommendations. Obviously, we're going to need a decision tree for that, so let's jump right in. So we're back, and we're going to talk about the decision tree for self-treatment of headache. I'm here with Dr. Tia. She's one of the family physicians that I work with at Southern Illinois Healthcare Foundation, and we're going to walk through this together. Go ahead and say hi, Dr. Tia.
Hello, everyone.
All right, isn't she nice? So the first thing we have to do is, does the patient have a complaint of headache? Don't treat a headache if it doesn't exist. Would you agree?
I definitely agree.
The next thing that you have to do if they do complain of a headache is we need to perform some type of symptom assessment like old cards or PQRST, or some even use something called Socrates. I don't care, but just make sure you go through the specific different types of symptom assessment like onset, location, duration, characteristics. The next and most important piece of this is exclusions for self-treatment. So when do we need to send these patients to see Dr. Tia? Well, the most important one is severe head pain. Also, if the pain persists for longer than 10 days, regardless of whether you're treating it or not, if they're in the last trimester of pregnancy, less than 8, or have signs of a high fever or signs of serious infection. If they have liver disease, they consume more than 3 alcoholic drinks per day, or if they have headache associated with some underlying pathology, like let's say they just fell and hit their head. We also want to make sure that we refer patients who have symptoms consistent with migraine, but no formal diagnosis from Dr. Tia. So we got to send them to you to get the formal diagnosis, right?
Right.
All right. So if you think that they have those symptoms of migraine like nausea, vomiting, photophobia, phonophobia, you need to get them over to see Dr. Tia. So once we've done this medical referral to Dr. Tia, if they do meet those exclusion criteria, send them on. If they don't, then we need to ask, are the patients using analgesics more than 3 days per week? This is very important because using it for more than 3 days a week can lead to something called rebound headache or medication overuse headache. If they are using for more than 3 days a week, you need to have them back off the analgesic for a few days. And if the headache doesn't seem to get a little bit better, then it's time to send to Dr. Tia. You'd be happy to see him, right?
I would be very happy to see them.
So we really want to try to avoid medication overuse headache. If they aren't using for more than 3 days a week, then we need to ask them whether or not they've been diagnosed with migraine, or if they have symptoms typical of sinus or tension headache. If they don't, we need to then think about medical referral to Dr. Tia. If they do, now we can recommend appropriate therapy. All right, are you guys ready to start recommending appropriate medical therapy? Let's do it. So we need to start by looking at some of the rule-out symptoms. We need to make sure that they don't have asthma, nasal polyps, GI ulceration, symptoms of gout, any kind of coagulation disorders or on an anticoagulant, hypertension, CHF, chronic kidney disease, or an aspirin allergy. If they have any of these, we really should probably avoid salicylates and maybe even NSAIDs. If they're less than 12 years of age, we need to stay away from naproxen because of labeling. And if they're less than 15 years of age, we really need to stay away from salicylates if they have viral symptoms present, because that can lead to Reyes syndrome, and that can be a very dangerous complication. So remember, we got to look at all of these exclusion criteria first. If we don't meet any of these, now we can start thinking about recommending therapy. For tension type headache, we like acetaminophen, NSAIDs, or salicylates as appropriate. If it's migraine, we tend to like NSAIDs or salicylates as appropriate. Now, what do we do for follow-up after we've recommended this therapy? If it's a chronic headache, let's follow up after 4 to 6 weeks and see if they've received adequate analgesia. If they have, then you want to continue using that, but make sure not more than 3 times per week, and continue to follow up. If they're not receiving adequate analgesia, guess what? They're coming to you, Dr. Tia. If it's severe headache, we need to follow up within 10 days, and then again follow the same pathway. And if it's episodic headache, then we're really okay by following up at 6 to 12 weeks. Remember that we as pharmacists have a very important role to play in the management of headache, and because of all the access issues that are out there, don't be scared to recommend appropriate therapy for headache, even migraine, when exclusion criteria are not present. I'd like to thank my esteemed colleague and our co-host today, Dr. Tia. Say bye, Dr. Tia.
Bye now. Good luck treating all those headaches.
All right. What a fun day.